Every millimeter of a needle's trajectory is the result of a specific clinical choice. This brief hesitation before the skin is punctured marks the final step of a complex internal assessment. Choosing the wrong site leads to immediate physiological failure. The vessel can rupture, causing a painful hematoma, or the fluid can leak into the surrounding tissue, a complication known as infiltration. To avoid these outcomes, practitioners do not simply scan for the most visible blue line. They follow a defined anatomical hierarchy to determine the most viable point of entry. This hierarchy functions as a mental decision matrix. The clinician is constantly weighing the urgency of the treatment against the physical limitations of the patient's vascular system. A successful first attempt is the measurable result of this real-time risk assessment. This guide places the forearm at the top of the search. Specifically, the cephalic vein, running along the thumb side, is the primary choice. It is considered the gold standard because of 3 physical traits. It is large, superficial, and provides the most direct path. However, clinical priorities change during a trauma or cardiac arrest. When a patient requires a massive volume of fluids or life-saving medication in seconds, the forearm is bypassed. In these high-stakes scenarios, the target shifts to the median cubital vein. Located in the antecubital fossa of the elbow, this vessel is the designated site for large-bore needles. While forearm veins are ideal for steady maintenance, they lack the heavy-duty capacity of the elbow's larger venous network required for rapid infusion. Ultimately, the choice of site must perfectly align with the volume requirements and the immediate clinical needs of the patient. In practice, primary vessels are often unavailable. Severe dehydration, previous physical scarring, or vessels that roll under pressure force clinicians to look elsewhere. The guide identifies secondary options further down the hierarchy, like the basilic vein or alternative superficial forearm veins. If exhausted, the search moves to the dorsal veins on the back of the hand, a final resort. However, the anatomical search stops immediately if a site meets specific exclusion criteria. As shown in the restricted list, a needle must never be placed in infected tissue, burned skin, or edematous areas. Access is also prohibited in limbs with AV fistulas or post-mastectomy sites due to lymphedema risk. A physically perfect vein is medically useless if the insertion violates the patient's broader physiological safety. Navigating the anatomy is the prerequisite. The success of the procedure now rests on manual execution. Mechanical success begins with the tourniquet. Applied above the site, it restricts venous return to the heart, forcing the vessel to engorge and become visible through the skin. The tips for success emphasize confirming site with touch. Practitioners palpate the vessel, feeling for the distinct bounce of a healthy vein. To prevent sliding, clinicians anchor the vein, pulling the skin taut to secure the target. Throughout these mechanical steps, the practitioner must also manage the patient's pain and ensure their overall comfort is maintained. Mastery of the IV stick requires bridging the gap between textbook geography and split-second tactile precision.